So hello everyone and welcome to today's webinar. The title is Level Up Wound Healing, Treating What Beyond What the Eye Can See. My name is Rafael Nishida and I'm the Senior Marketing Manager here at Smith+Nephew. I am honored and I have the pleasure to introduce our guest speaker, Dr. Kevin Wu. Dr. Kevin Wu is a full professor at Queen's University, Faculty of Health Science in Kingston, Ontario. He also holds an academic appointment at Western University here in Canada and at Curtin University in Australia. Dr. Wu's research focusing on developing innovative solutions and technologies to promote chronic disease management and wound care. He has also authored numerous peer-reviewed articles, book chapters, and best practice guidelines that have shaped the delivery of care in Canada and internationally. He's also the inaugural president and scientific advisor of the Canadian Pressure Injury Advisory Panel. He is the chief research officer for Nurses Specialized in Wound Ostomy and Continence Canada, NSWOC, and also a fellow NSWOC and a certified NSWOC. Before I passing the word to him, I just have a couple of housekeeping items. We invite you to submit all of your questions by typing them into the questions panel found by clicking on the Q&A icon along the bottom menu. You may submit your questions at any time. We will collect them and address them during our Q&A portion at the end. A link to the certificate of attendance will be available in the chat at the end of the presentation, so please click the link to download your copy and complete with your name. It will also be available in the follow-up thank you email. We also ask you to please complete the survey that will appear in your browser at the end of the presentation. So with that being said, welcome Dr. Wu. Thank you.
Great. Thank you so much, Raphael, for such a kind introduction. And I also want to thank Wounds Canada and Smith+Nephew for organizing this event. And great to see so many people joining us this evening. And I'm in Canada right now, so it's lovely, sunny, warm weather that we're having at the moment. So I appreciate people spending time for an hour with me. So the title, as Raphael mentioned, we're talking about level up wound healing. And specifically, I want to mention about the PICO dressing, the negative pressure wound therapy, in terms of how that can help with the wound healing and part of our wound management approach. So this is my disclaimer. So I want to start with the conversation about why we have to think about NPWT, negative pressure wound therapy, and specifically the type of dressing that I'll be discussing this evening with you is the PICO dressing. And one of the sort of catchphrase and the headline is really about thinking about the type of therapy we use that can actually promote wound healing from above, from below, and from beyond. So I think that's kind of a catchy way to remember why PICO dressing is different compared to the traditional negative pressure wound therapy. And I'll explain a bit more about, what's going on above, what's going on below, and what's going on beyond as well. So just want to refresh people's memory about some of the chronic wound environment and how the negative pressure wound therapy may be able to modulate local wound environment in terms of promoting wound healing and facilitating the closure of wounds. As we're aware, chronic wound, well, I think we still don't really have a universally accepted definition for this term. Some people call it difficult to heal wound, hard to heal wound, protracted wound, so on and so forth. Obviously, it's not just about the chronicity of the wound, but there's actually phenotypic expression changes in wound environment, making this types of wounds very difficult to progress into healing. And many sort of basic science research has informed us in chronic wound environment, there's a buildup of inflammatory cells, mediators inside the cells, and there's a lot of fluid exuded into the wound environment because of the inflammatory response. So with excess amount of exudate, it can influence the wound healing process, and especially with the inflammatory mediators. The right amount of inflammation is so vital to the wound healing process. We need inflammation in order to clean up the wound surface, but prolonged, excessive amount of inflammation can actually quite damaging to the wound environment and killing all the healthy cells and growth factors as well. So this type of PICO dressing, if you're not aware, and again, as a refresher for negative pressure wound therapy, we'll call it sort of 360-degree dressing technology because it exerts negative pressure around the wound in a 360-degree angle in all aspects of the wound surface and beyond in order to promote wound healing. So what it can do is to remove excess amount of fluid and lock it away inside the dressing itself, and also allow a lot of fluid to evaporate from the dressing to modulate the wound environment. So just to convince you in terms of how the single-use negative pressure wound therapy is quite different compared to the traditional negative pressure wound therapy, you can see the kind of schematic presentation of where the pressure is located in the sort of a cross-sectional schematic presentation of the wound environment. In the Pico dressing picture above, you can see that there's a lot of red color, there's a lot of yellow and blue color, representing that there's pressure. And what impressed me is the amount of pressure that goes beyond the wound margin versus the traditional MPWT. You can see the vertical pressure that primarily exerts into the wound environment, not so much in the periphery area. And why is it important? Because we just talked about the inflammatory mediators. We just talked about edema being a vital process that can impair oxygenation, that can impair the wound healing process. So what the negative pressure can do is by applying negative pressure into the peri-wound region, we can actually reduce the amount of edema, take away some of the excess fluid. We can facilitate oxygenation and better wound healing process. And talking about oxygen, we also know that in chronic wound environment, there's a hypoxic environment. Basically, there's not enough oxygen to support the healing process. And that's why we see the healing process is slowing down, just not enough blood flow and oxygen delivered into local wound environment. Again, with the Pico dressing, we're able to reduce the edema, improve blood flow, and actually there's some data to suggest that by using Pico dressing, by using negative pressure wound therapy, we're able to promote growth of new blood vessels. The term is angiogenesis. What about defective cells? A lot of the cells we identify in a chronic wound environment, from some of the biopsy studies, we know there's a excess amount of senescent cells, meaning those cells are kind of old. They're not able to perform the normal function. So usually the keratinocytes, the healthy cells, will be able to produce healthy growth factors to promote wound healing. And also the fibroblasts will be able to migrate from the wound edges into the wound surface to promote tissue growth. So what we see with the chronic wound environment, there's excess amount of this senescent cells that are not really performing what they're supposed to be doing in terms of filling up, promoting granulation process. And what the Pico dressing and the negative pressure wound therapy can do is through these biomechanical forces that it can stimulate the tissue growth, stimulate new cells producing locally in the wound environment to replace those senescent cells. And that's why we see some better granulation process. We see better wound healing at the end of the therapy. And the last sort of component I want to discuss is the final phase of wound healing. And you can see that I'm walking you through the different phases of wound healing and how negative pressure wound therapy would be appropriate, whether it is in the inflammatory phase, the granulation phase, or even at the final epithelialization phase or the modeling phase. Because at this phase, we want to sort of minimize the disturbance of the local wound environment. A lot of the fragile granulation tissue and the new epithelium can easily be removed and disturbed by the traditional negative pressure wound therapy. So we actually did quite a few different studies, including a randomized control design study that I will be sharing with you, that validating the fact that by using single-use negative pressure wound therapy, by using Pico dressing, we can reduce the damage and disturbance to the local wound environment. As you can see in this experimental study in a lab using non-human skin, that basically from comparing the results from day 0 to day 12, you can see that with the contrast between the single-use negative pressure wound therapy versus PICO dressing in the kind of yellow color. And there's a significant difference in terms of the percentage of reepithelialization at the end of day 12 versus for the traditional therapy, there's only less than 10% of new epithelium. I think the message is every time we remove the dressing, every time we change the dressing, there's always a risk of removing and causing more skin stripping and removing the epithelium along with it. And this is the randomized control design study that was published in 2019 by Dr. Kirsner and his group. It's one of the sort of big randomized control design study, and you know how rare they are in terms of looking at wound healing, and in this case, comparing traditional negative pressure wound therapy versus PICO dressing. And one of the and it demonstrated that by using single-use negative pressure wound therapy, there's a significant improvement in wound closure and reepithelialization at the end versus the traditional therapy. And there's the number of hypotheses, and you can imagine what they are. We just talked about some of the key elements and key differences between the two types of therapy. So with the single-use therapy, there's less maceration. There's also the right amount of material in sort of get into the wound environment versus with the traditional foam-based negative pressure wound therapy. A lot of times there's a risk of too much fillers or underfilled in the wound environment. When there's not enough material in the wound environment, then it's not really producing the negative pressure that we aim for. Versus if there is too much overlapping and overfill, then you're basically creating a barrier for wound healing and the granulation tissue to grow into the wound environment. And not to mention about the overlapping can cause maceration, can cause skin stripping and skin damage in the peri-wound skin as well. So again, for people not familiar with PICO dressing, it's a multi-layer technology. And there are a few different layers, including a silicone adhesive layer, the airlock technology, the super absorbent core, and then we also have the top layer of film. And this is a sort of a short animation just to illustrate the performance of PICO dressing locally in the wound environment. You can see this is a wound environment. The wound bed is repaired and it's clean. There's no necrotic tissue. And with PICO dressing for a depth of about 2 centimeters, there's really no need for putting any material underneath the PICO dressing. So in this case, you can see that there's the first layer, the silicone dressing, with the right amount of perforation to allow fluid to exude and escape from the wound environment and get into this absorbent core, into the airlock technology layer. So once it's getting into this layer, the fluid is locked into the absorbent material. There's a very minimum amount of lateral movement. And this is ideal because if there's too much lateral movement, you can actually cause maceration, and there's no redonation of fluid back into the surface itself. So again, minimizing the risk for maceration and skin damage in the peri-wound skin. And finally, you have the back film, the backing of the dressing. It has the ideal amount of the porosity that allow vapor to escape from the wound through the dressing into the ambient environment. Again, sort of almost like this continuous modulating system to allow fluid management to be optimized. And definitely where you think there may be a need for a filler with the deeper wound, with a wound with significant amount of depth or dead space, you can consider using a foam and using other type of dressing material into the wound as a filler as well. So hopefully, this really gives you a good sense in terms of what the technology is available to you, and it's very, very easy to use. When I first brought the technology to my hospital, a lot of nurses kind of been looking at me and say, Well, this negative pressure wound therapy is so complicated, and we need wound care nurses to help me to apply the dressing material. And I think we can just teach people in about 10, 15 minutes, explain what was being done, what's involved. A lot of times they may not understand truly the mechanism behind it. But the application itself, I can actually teach family members how to apply directly on the wound. So just want to walk you through a few different case studies here. So this is a first case, an individual, a 64-year-old patient with a heel ulcer for about 3 months, and the wound actually was not healing. So we decided, well, perhaps it's time for us to think about something different to manage and modulate this wound. And you know that heel ulcers are challenging to manage because there's constant friction and pressure and so on and so forth. And we definitely looking at ABCD, looking at a holistic approach, holistic assessment approach. So we determine there's enough circulation. This wound is healable. There's no factors that can really significantly impair the wound healing process. We treated the ulcer with a silver dressing because we thought that, well, perhaps what we can do is to kickstart the healing process by using antimicrobial dressing. And we now convince ourselves that we have managed the local bacterial burden, and that's no longer a factor that is impairing the healing process. And the healing is still kind of sluggish. So at that point, then we think about perhaps we need to address the local wound healing with more advanced technology. So we try PICO. You can see that at the beginning, the wound was about 3 by 2 centimeter. There's still a little bit of yellowish material, sort of fibrinous material, and it's not really quite fully granulated at that point. And we know that the granulation tissue present in the wound looks pretty healthy. So we have adequately addressed the local burden, the bacterial burden. We apply the PICO dressing and come in different size and shape. And this is a nice little shape because it's kind of designed for some of those elbows, heel, knees area where you have this sort of awkward contour, and this allow the dressing to fold around and mold around the contour, the body contour. And you can see that the port is quite soft. It doesn't stick out like some of the traditional therapy, and is quite comfortable to wear. Of course, hindsight, we should have sort of moved a little bit away from the Achilles area because the patient kind of sort of lay in bed from time to time. So what we see here is the result of the PICO dressing after 1 week. The wound gets smaller, and from the 3 by 2 to 2 by 1 centimeter in size. You can see these kind of the shiny new epithelium in the peri-wound skin, indicating that actually new growth and new tissue, new cells that sort of surface to the area and start migrating into the wound environment. And that's the kind of, so we're smarter this time, and we actually moved the dressing to the malleolus area. And what I want to show you in this picture with the PICO dressing is that you can see the stain left on the dressing. It's very, very localized. It's locked into dressing itself. And some people may ask, well, this is a small area. Why are we using such a big piece of PICO dressing? It's kind of a waste, isn't it? And the fluid is actually not that bad. And well, the key message is, remember, we're trying to modulate the wound healing process from above, from below, and from beyond. So again, that's the catchphrase. So you can appreciate that there is some slight edema with this patient, even though we ascertained the ABI, we know that there's enough circulation. There's still some edema, and the patient wasn't so keen in terms of wearing compression therapy. So the PICO dressing can actually promote is the reduction in edema, not just in the local wound environment, but potentially in the sort of beyond that wound margin as well, and trying to reduce the amount of edema going on that can compromise the perfusion, compromise the blood, the oxygenation to the tissue, because oxygen has to travel from the blood vessels to the wound surface, to the tissue. And if there's a long distance because of the edema, then you can actually, the oxygen got diffused from the travel, from the distance that they have to travel to the wound surface. And by reducing edema, we're reducing distance, we make oxygen more available to the wound bed. So by week 2, and you can see the wound, literally, there's a big difference compared to the initial picture. Now the wound size reduced down to 0.5 by 0.5, and that's up to 96% of size reduction. Again, I'm showing you the sort of close-up of the PICO dressing, and there's a very localized, very small amount of exudate, and that's ideal for PICO dressing. When you're dealing with a heavily exudative wound, PICO dressing may not be the most appropriate dressing. So I'm going to talk about a second scenario, and this is a 29-year-old gentleman with a history of spinal cord injury. And he was in the rehab facility, and he unfortunately developed pneumonia. He was on he had a tracheostomy, and of course, those individuals at high risk for developing all kinds of infection, including respiratory infection. So at that point, there's a need for antibiotic treatment because his blood pressure was dropping, and there was an increase in the white blood cell count. So IV antibiotic therapy was recommended by the infectious disease group, and there was a challenge in terms of finding the IV access to the usual places where we can find veins. So in this case, the only place left was actually on the feet, and a lot of things can go wrong when you have IV therapy in the lower extremity, and it did get a little problematic because there was interstitial fluid. The IV got extravasated and basically causing local injury. So when I first summoned by the nurses to look at this wound, they said, "Oh, Kevin, look at this wound. I don't know what this white discoloration is. Doesn't look so bad, right? So there's a little pinkish color. So I think this is okay. So we can just put a dressing over it, right?" So I actually looked at this wound. I was kind of, a little gobsmacked. I sort of opened my mouth and said, "Well, okay, this is just not a very good scenario," because basically, when you touch the surface area, it's a little bit cool to touch, not the normal temperature. And there's a little induration in the peri-wound skin region, including the wound bed. And you know that this is not healthy tissue either. So basically, this is the early declaration of the tissue damage caused by the extravasation, caused by the injury from the IV fluid, from the antibiotics. So this is going to be a very significant wound. We recognize that. So of course, I start debriding this area and creating a wound. And you can see that after a series of debridement, sharp debridement to the area, creating a larger size of the wound. At this point, we create a wound 8 by 7 centimeter in size. There's still a little bit sloughy tissue. I scrape it off from time to time. And at the same time, I thought that, well, perhaps we need to minimize the discomfort and utilize PICO dressing. And we did think about perhaps negative pressure wound therapy as a place to promote autolytic debridement and desloughing. And I really want to sort of test out the theory a little bit, and not all wounds that need to be fully granulating or fully cleaned before we apply the PICO dressing. I think that's an important key message too. Because we want to remove some of the sort of stringy, sloughy, soft tissue from the negative pressure wound therapy. So again, after 1 week of therapy, you can see that what the PICO dressing looks like connected to the pump. And locally, the dressing, the fluid, there's a strike through there. You can see that it's very, very localized. It sort of decompressed from the negative pressure. Upon removal, we look at the wound, it looks a little cleaner. And you can also appreciate the pattern left behind from the negative pressure wound therapy. There's some new granulation buds on the healthy wound bed. And also there's the indentation around the peri-wound skin region as well. So remember, so from above, from below, and from beyond. So we're cleaning up the wound, we're addressing the local inflammatory response, modulating the wound environment. We also want to promote from below the granulation process and also the angiogenesis, new blood vessels growing into the area. And from beyond, we want to minimize the edema and bring in more blood vessels and bring in more oxygen to facilitate the healing process. So, and the other picture on the right-hand side, we cleaned up a little bit, and that's why it looks a little redder because we sort of cleaned it with a little bit more, sort of more intention. So now by week 2, you can again see some good healthy granulation tissue that's slightly growing into the wound environment. And we thought that perhaps there may be some friability that we want to address, and also presence of slight amount of hypergranulation happening. So, and that's why I thought that perhaps we need something antimicrobial to put under the PICO dressing, just trying to optimize the healing potential, given the fact that we actually failed this patient by giving him this wound. So we are obliged to use all kinds of tools in our toolbox to help with the healing process. So what you see here, the orange colored powder is the iodosorb powder. And for people not familiar with iodosorb, it is an iodine-based cadasamer type material that comes in different types of vehicle. It could be a paste, it could be ointment. In this case, this is a powder. I like the powder formula because it allows me to sprinkle the wound surface with small amount of powder or larger amount, depends on the wound environment, depends on where I think we need the therapy, the treatment for bacterial damage. So in this case, with the negative pressure wound therapy, I don't want to use a heavy amount of ointment, the powder, because that may still have a risk for affecting the efficacy of negative pressure directly on the wound bed, because less is more. What really produces the outcome is the negative pressure. So I don't want to have any barrier that can affect the interface for this negative pressure. So in this case, I sprinkle a little bit of iodosorb powder and then put the PICO dressing on top. And you can see that, again, just trying to show you all those new granulation and all the indentation, suggesting the negative pressure wound therapy is working from within and from outside. So, after 3 weeks of using the therapy and using the combination of antimicrobial dressing and the PICO dressing, you can see the wound bed is much cleaner. It's all cleaned up nicely. We no longer see the friability. Exudate control much better. We actually, and you can see that actually the edema got under control as well. And the wound size at this time is 3.5 by 3 centimeters in size, so 81% of size reduction. So definitely there's a significant improvement in wound size, and there's accelerated re-epithelialization. You can literally see the new epithelium there, and that's part of the kind of interesting mechanism that we minimize the disturbance to the wound and also the peri-wound skin. So we continue with the therapy for 5 weeks. And of course, the pearl wisdom around using any type of therapy and technology is the ongoing assessment. We assess the response to the wound treatment every week. And by week 2 and week 3, we usually stop and pause and evaluate whether the therapy should be continued. And when looking back at week 3 picture, we see that there's a significant improvement already. So we want to continue with what we have seen so far. And so that's why we continue beyond therapy beyond week 3 to week 5. And you can see the healing continues down to the size is reduced down to 2 centimeter by 1 centimeter. So at that point, basically, you can see so much new epithelium there, and the wound size is so small and so shallow, we decided we can discontinue the PICO dressing and change to a Actico Flex with the foam dressing to modulate the wound environment, and we change the dressing 2 times per week. And I think ultimately this wound closed. Of course, sometimes we're so excited when the wound closed and I forgot to take the picture. But anyway, so this is really a time series of pictures showing you from the beginning with the wound size, the size of the wound with a lot of sloughy tissue, friability, unhealthy granulation tissue, slight edema in the pedal area. And over time, we're able to modulate the wound environment, clean it up nicely, reduce the inflammatory response, reduce the local bacterial damage. And now you can see that the wound healing has kind of almost accomplished in the end. All right, I'm going to show you the last case, and always saving the most dramatic to the last, right? So this case number 3, this is a 61-year-old female. And she came to a hospital for rehabilitation. Actually, she was about to be discharged home and unfortunately sustained a fall. And this is from after the fall, this trauma related result in a very large local response injury response with edema and the blistering and the inflammatory response, very, very significant. Very obvious to us on the picture here. And other sort of relevant medical history. She's diabetic, so I think that raised a red flag in terms of the risk for infection and also the risk for wound healing management, because a lot of people with diabetes, wound healing is always compromised because of the glycosylation of cells and other factors and circulation problems. At the same time, talking with circulation, she also has a history of lymphedema, and you can actually appreciate that the size of the leg is quite large. The circumference is bigger than usual, and she's been sort of getting some very mild compression therapy because that's what she can tolerate and agreed to wear. Of course, the best compression is whatever patient allow herself and themselves to wear. So we decided to compromise a little bit. But anyway, I'll tell you the story as this story continued to unfold. Basically, at that time, I was a little bit concerned about the amount of edema and swelling around the circumference of the lower extremity, around the calf area. And one of the biggest concern is when there's significant amount of edema circumferentially, it can actually create compartment syndrome and cutting off the circulation. So anyway, we send the patient back to the emergency department and for some sort of evaluation, some diagnostic tests. And basically, we follow what we call a step up, step down management paradigm. And if you're not familiar with this model, it's a paper published by Dr. Schultz and his group back in 2017. Really changed the way we look at and consider wound management. And what they're advocating in this model is we need to be very aggressive, be prepared to look at sharp debridement in instituting and integrating aggressive therapy like negative pressure wound therapy or some other type of growth factors or dressing to promote wound healing. And then we gradually de-escalate our intervention as the wound continue to improve. So I think I bring this up at this point because that's exactly what we what we're doing in terms of following this step up, step down paradigm. So now we have a wound. We have a very complex patient with a very difficult to heal wound. So what we need to do is start with the tissue management, looking at what we need to do to clean this area up to prepare the wound bed for wound healing. So when she came back to us, so now the area is looks more mature. The blister has sort of subsided, but what's left was this sort of big hematoma, and we sort of lens it open, incised the area, evacuated all the necrotic tissue and the blood clots inside the tissue. And basically, you can appreciate the amount of damage from the fall, and all the materials kind of all the very thick clots that can quite easily dislodged from the sharp debridement. So there's a little bleeding, but it's not so bad. So at that point, by day 6, we continue up with ongoing almost daily debridement in terms of cleaning up the wound bed. So you can see some improvement in terms of wound surface. And the interesting thing is every time we clean up the area, when we came back, there's always a little bit more sort of resurfacing of necrotic and unhealthy tissue, if you may. So, but anyway, we know that, again, based on our assessment with our ankle brachial pressure index evaluation, we identified this lower extremity area it's healable. There's enough arterial blood flow to support wound healing. The question is what we need to do to get the healing process started. So what we did is measure the wound is 25 by 17. But there's the areas start to filling in. There's less depth to the wound surface. And by day 12, with ongoing debridement, we actually use some of the enzymatic agent to remove some of the sloughy tissue and unhealthy tissue. We see sort of islands of granulation tissue and hypergranulation tissue. That's not too surprising in terms of very discrete and preferential area that respond to therapy. So we continue with the ongoing treatment, and you can see on day 13, there's not a significant change in wound size, 24 by 15, but the wound looks a little cleaner, healthier. We're moving in the right direction. So going back to the step up, step down paradigm, we look at the use of enzymatic agent. We use sharp debridement to clean in combination to prepare the wound bed. So now, after 20 days, we came back to conduct our assessment. So it's been about 3 weeks already. And we thought that things were on the right track. And all of a sudden, we start to see the sort of emergence of some of the unhealthy tissue. You can see the granulation tissue got a little bit of friability, got this sort of unhealthy, dusky discoloration, not extremely healthy looking. And there's also increased amount of exudate and smell. And pain is also one of the biggest concerns that she has. And every time I see her, she always complained to me that the dressing change was a torture to her because of the pain issue. So with this increase in pain, increase in odor, increase in drainage, it also points in the direction that we're dealing with local infection with the biofilm problem potentially. So we decided to place some Acticoat on the surface in order to address the local bacterial burden again. And we also, from the Acticoat, we changed to the iodazole powder, and we just talked about the iodine powder already. So you can see that in this case, I actually apply heavy amount of powder because the amount of tissue damage, the amount of exudate and odor I need to manage. And why I switch from the silver to iodazole is based on an infection management algorithm that there is some data evidence to support the use of iodine-based dressing for biofilm-related problem, versus silver may not be the best choice when it comes to biofilm problem in the wound environment. So, and that's why that's the key decision determinant why we think that we need to use the argan-based dressing at that point. So after 21 days, I start to know this patient much better, and she was a little bit more amenable to the use of appropriate compression therapy. So and that's why you see the some of the indentation around the area, because we start using stronger compression therapy to really facilitate edema control. So you can see that by day 28, there's a significant difference compared to the previous pictures. There's more granulation tissue and less amount of unhealthy tissue, and we also appreciate there's a continued improvement in the wound size. Now the wound is 23.5 by 14, and by day 35, we see another sort of improvement. Still sort of a kind of very sluggish, slow improvement. So by day 38, after we cleanse the area and we see that the wound actually much better, very healthy, almost 80% covered with granulation tissue. The wound size at that time was 21 by 13 in size. There's still a little bit of edema going on despite the therapy, despite the compression therapy. So, of course, we prepared this wound bed over the last 21 days, the last few weeks. Now the wound bed is prepared for some more advanced technology to look at the edge effect, how we can pull the edges together by using negative pressure wound therapy in this case. And because given the size, we definitely want to think about, in this case, particularly with the MPWT able to facilitate faster wound healing. Because the longer the wound is going to be exposed to the environment or being there, the more likely that there will be another infection happening. So, and you can see that in the middle of the picture, the picture of PICO dressing applied on the wound on day 43, connected to the pump, and by day 64, and that's 3 weeks after we have initiated the PICO therapy. Now you can see a significant improvement in the wound size, down to 18 by 10 centimeters. Again, want to point out the indentation left behind by the PICO dressing, and you can see the pressure exerted directly on the wound surface, promoting new granulation tissue, new buds going into the wound, and also the pressure exerted in the peri-wound skin and beyond the wound margin, beyond the wound space. So you can see that this is a sort of, again, the time series picture showing you from the beginning to the end. We're able to modulate the wound environment, facilitating healing process, making this wound heal faster. And this patient, of course, there's only a limited amount of time that we can keep patients in the rehab hospital. So at that stage, we decided that this patient is ready to be taken over by home care service, and she was discharged home with the PICO therapy. And that's why I don't really have the final picture to show you, but I saw her actually in the hospital a few weeks after her discharge for other problems, and the wound actually was practically almost closed with the therapy. So I was quite pleased with the outcome, and the patient was very, very pleased with the outcome as well. And one thing, of course, she actually highlighted why the therapy was important to her, not just from the clinical perspective, but she mentioned that the pain actually was reduced significantly with the PICO therapy. There's less frequent dressing change because the dressing was able to manage the exudate. And also, we can see that there's a significant improvement in the wound reduction. So the faster the wound healing, the faster patient can get back to her normal life, right? So it's an improvement in terms of the quality of life for sure. So this is a sort of quick review of the mechanism involved in NPWT, and also giving you a few case scenarios just to illustrate how the therapy is integrated in my practice. Sometimes I wonder whether we should be using negative pressure wound therapy early on so we can bypass some of the steps and get the healing process started. Um, but anyway, we always learn something new, and when we reflect on our practices and we go back to look at our cases. So hopefully this is informative and helpful to you. As I said, some of the elements, maybe some of the information, may be a refresher for you, just to reinforce some of the key messages you've learned in some of the other conferences and some of the lectures you've learned already. But I think the important thing is there's always a place for negative pressure wound therapy. And that's why, keep that in the back of the mind when you think about the wound is not healing. And when you need to really promote the edge effect, when you need to think about the type of therapy to minimize the tissue damage from, and also promote healing from above, from below, and from beyond. And that's the key message I want to convey to people tonight. All right, I think we have time for questions, Rafael?
Yes, awesome. Thank you, Dr. Wu. Let's begin our questions and answer session. As a reminder, you can still submit your questions through the Q&A icon. I do have a couple of here that I'm going to share, and I'm trying to combine some of the questions in the same topic. The first one, it is, when would you consider that a wound does not need a filler with Pico, and when might a filler still be required? And then the other question regarding to the same topic, which is a depth that you start using a filler, and what is the maximum depth wound for you to use Pico?
Yeah, that's an excellent question. Thank you so much for whoever raised the question. And I think I alluded to that earlier, maybe not at length. So the ideal depth for Pico dressing to address wound healing and the dress able to conform into the wound space is the 2 centimeter threshold. So beyond that, it will be difficult for the dressing to sort of fold into the wound environment. Because as I mentioned earlier, alluded to that earlier, you want to ensure a good contact interface between the Pico dressing and the wound surface itself. So the level that conformability is so important. And yes, there are situations that we might have to use the filler, may not be the most ideal. But of course, in some situations, especially a home care environment, it's a very easy to use technology. And for a not too exudative wound, Pico is the ideal dressing for negative pressure wound therapy. So in those cases, if the wound depth is beyond 2 centimeter, then you might consider using a filler. And there are a variety of different fillers. The important thing is whatever you have chosen should allow the negative pressure to be transferred from the Pico dressing into the local wound environment. In other words, it should not be occlusive. It should not cause a blockade to the suction channel, so to speak, on the dressing itself. So that's why I use dressings like I've used Ectico Flex dressing. It's lots of fenestration on the dressing itself. For antimicrobial action, I've used the iodosil powder. I wouldn't use paste because paste may be a little bit too thick and too occlusive and have a tendency to clog up some of those suction negative pressure channels on the dressing. I wouldn't use hydrofiber either because hydrofiber, as you may be aware, that it turns into gel-like consistency. So it doesn't allow the vaporization, doesn't allow sort of fluid to escape and air to escape and exchange. So there's no negative pressure if you use a hydrofiber in the wound underneath the Pico dressing. So a variety of dressings like gauze base, and you can use a porous foam material into the wound surface as well. So hopefully that gives you some ideas.
Thank you. The next question is coming from Farah. And the question it is, can Pico be used if wound has necrotic areas?
That's a wonderful question. It depends. I know it's a kind of not a sort of a not trying to be flippant about this, but I think a lot of times depends on what we mean by necrotic tissue. So if there's a thick layer of eschar tissue, I wouldn't use any type of negative pressure wound therapy, whether it's PICO or traditional MPWT, because it's just not very cost effective and efficacious to apply a very expensive therapy on a wound bed that that is covered by thick necrotic tissue. So none of the therapy, none of the negative pressure can actually apply in the healthy granulation tissue. So you do need to have at least some area of granulation in order to facilitate healing. So if it's 100% full of soft, 100% full of necrotic tissue, I would definitely say this is inappropriate indication for the use of MPWT. So the area needs to be debrided with a sharp mechanical other means of debridement. And depends on the type of tissue as well. And we know that we have seen, even with small amount of eschar tissue can be softened up underneath the PICO dressing or under the NPWT that may facilitate further debridement and removal. And definitely some of the slough can be liquefied, can be turned into sort of more sort of liquidy kind of material and get removed from negative pressure. So I would say that there's no magic number. I would say that at least there should be 50% of granulation surface to consider MPWT, and also depends on the thickness and the type of tissue. And one more sort of caveat is when you're dealing with acute infection with for wounds that have a lot of necrotic tissue, again, the best practice recommendation is to remove some of those necrotic tissue as quickly as possible, perhaps using sharp debridement when there is enough blood flow, when there is good indication that the wound is healable. Negative pressure, even though it may be effective, but it may take a longer time for the tissue removal and debridement. So that's why if you're dealing with an abscess or dealing with a fasciitis, necrotizing fasciitis that has not been debrided, obviously negative pressure wound therapy is not appropriate at that point.
And it is good because you already answered some of the other questions that are coming here on the same topic. Ryan sent a question. If negative pressure wound treatment is used on an area with bony prominence where the patient is no weight bearing or bed bound, does the dressing decrease the effectiveness of other therapeutical/pressure relief surfaces such as low air loss mattresses?
Interesting question. I think the answer is no, the quick answer. Just like, and I don't think there's a good comparison, or people have used the analogy, but it is a multi-layer material when you think about the PICO dressing, and I'm not suggesting that it's able to perform like some of the multi-layer foam dressing in terms of reducing the friction and shear and pressure. But from my perspective, there's still some sort of very, very small amount of movement, and there's definitely does not affect does not produce additional pressure to the local wound environment. So you can continue with your therapy with your reposition device. And of course, even if you're using the therapy, the MPWT, it doesn't mean that you forget about all the other best practices. You still have to reposition patients. You still have to think about footwear for diabetic patients. You still have to think about compression therapy for venous leg ulcer. So all of those best practices is part of the package. It's a bundle approach. Now you got this additional tool that fits nicely and serve as a complementary approach to all the other good practices that we do to promote wound healing. So I hope that I answered the question that MPWT therapy doesn't affect the offloading devices, doesn't affect the type of air mattresses that you may be using for offloading or pressure redistribution. In fact, it's ideal. It's suggested, promoted to use some of those therapies in conjunction with NPWT to optimize and addressing some of the local wound etiologies.
Awesome. Thank you. I have a question from Allison here. Her question is there any role for PICO immediately post-op on surgical incisions?
Absolutely. There are some studies, and I think some of my colleagues have done some of those evaluation as well in orthopedic areas, in the hip and knee patients. After post-op, the wound still is well approximated, sutured, stapled, so they use the PICO dressing directly on the wound. As I said, the PICO dressing has the ability to modulate the wound environment, facilitate the healing process above, below, and beyond. You must be sick and tired of me saying that already. But anyway, so what it does is, especially with surgical wounds, even though it's approximated, well approximated, what you can do is actually reduce the amount of edema and also protect an area from external contamination by minimizing the amount of dressing change, the frequency of dressing change. In some of those cases, you may not need to change dressing that frequently. So with the PICO dressing, with PICO 7, you can change the dressing every 7 days. And there's also dressings that you can change every 14 days as well. So in other words, it's actually quite interesting approach to protect the wound and minimize surgical site infection by using PICO dressing earlier in surgical wounds.
Thank you. I think we are done with the questions because I just got a message here from the closing. So thank you. I know that there's more questions here, some from the commercial standpoint. We will get all of this information and then we will reply to everyone that sent their questions. So thank you, Dr. Wu, for your engaging talking and discussion. We hope you all enjoyed today's webinar, Level Up Wound Healing, Treating Beyond What the Eye Can See. Don't forget to click the link in the chat box to download your certificate of attendance and complete it with your name. A follow-up email will be sent next week with an opportunity to review on-demand presentation and again with a link to the certificate if you're unable to download it today. If you have any other questions, you can contact us. My email is raphael.nishida@Smith+Nephew, or you can also contact Wounds Canada at info@woundscanada.ca. Once you leave today's presentation, a survey for this webinar will appear in your browser, and we would appreciate if you could complete it to provide your valuable feedback. So on behalf of Dr. Kevin Wu, Smith+Nephew and Wounds Canada, I want to say thank you for joining us today. Thank you.